Next, we'd like to welcome Kenyon Farrow of the Treatment Action Group.
What's up, Clip? I know it's getting late, but what's up, Clip? Hi, as you just heard, I'm Kenyon Farrow. I am long title, the U.S. and Global Health Policy Director with the Treatment Action Group. And it's not important that I have a long title or any of that, but this is my first time back at CLIP, I think in 5 years. And if you had told me 5 years ago that I would be the policy director of a think tank that grew out of ACT UP New York, out of the Treatment and Data Committee of ACT UP New York, and that focuses specifically on, activism around research and development, watchdogging the drug companies, governments, the multilateral organizations like the WHO and PEPFAR and UNITAID and all of those players, to try to find, the best, most affordable treatments for everybody suffering from HIV, tuberculosis, or hepatitis C on the planet. I would have laughed you out of this fucking room. Because I didn't see myself. I had been doing HIV work. I was ED of Queers for Economic Justice in New York City, which no longer exists. And so HIV had been a part of my work in a lot of ways, and as a black gay man in my community and in my life since the beginning of the epidemic. However, like most people of color in this room, I was never, ever throughout our U.S. public education system encouraged to study science or math or those sorts of things, and didn't really see myself as somebody who could kind of engage in this particular lane, right? And so I think one of the things that's important as, and one of the reasons why I think that for those of us who are AIDS activists or focus on HIV, I think have so much interlap with reproductive justice on some issues that I'll be discussing on another panel today, so I'm not going to give all that away. Look for me in the program. But I think that one of the critical things is being able to, we say walk and chew gum at the same time, right? So that means that, like, as reproductive justice organizers and activists, as AIDS activists, we have to both focus on the social determinants and the things that we know are causing people in our community to suffer, right? So in terms of, criminalization, in terms of housing, in terms of, mental health, a range of things that, and poverty, right? Obviously the education system, et cetera. But we also have to engage science, what we would call the medical industrial complex. We have to engage pharmaceutical companies around diagnostics and treatments and et cetera, right? We don't have the luxury to take those things off of the table, right? And so I think those are two critical points of unity that I think that both AIDS activists and reproductive justice activists, I think, share in common. So real quick, a little bit about, how I see kind of reproductive justice issues interact with the three disease areas that I work on a daily basis. So in terms of HIV, how many people know about PrEP, pre-exposure prophylaxis? Raise your hand, okay? Pretty good number, right? So for those who don't know, in 2012, the FDA approved a drug that had been used for about a decade at that point for the treatment of HIV. It was found that taking that one pill a day, if you were HIV negative, would prevent an HIV infection, even if you had unprotected sex or you somehow were exposed to HIV, up to like 95%, right? So if we think about birth control, which is often the other way I make this comparison to people, right? It's about as effective as a birth control pill, but in terms of preventing HIV. However, we still face several barriers to people being able to access PrEP in this country. One of which, much like the beginning and the advent of birth control, it still is a part of a kind of a moral panic that if we give people access to another prevention tool that's not condoms that we've been giving people for 30 years, that somehow people are going to have sex. right? um, right? Ridiculous, but that is one of the thoughts. The other thing is, one of the things that's sort of happening because of the expense of the medication, different, whether it's Medicaid or different kind of payer systems are structuring who gets access to it and who doesn't, right? And so it's causing issues between particularly gay men and trans women, who are often kind of written into the guidelines of who should have access to PrEP first, and cisgender women who may want access to PrEP in communities. And one of the things that I keep telling people that the issue is with Gilead, the drug company, for pricing it that, right? That's causing the insurance industry to try to curtail who gets access to it. The issue is not between gay men and cisgender women, or between transgender and cisgender women. And so we have to think differently about that. When we look at tuberculosis, a disease that many of us probably thought was over, right? In 2014, tuberculosis replaced HIV as the #1 infectious disease killer of people globally. TB now kills 1.5 million people around the globe. If we think about HIV, well, we went from just 15 years ago, people having to take handfuls of pills that cause a lot of side effects, now down to 1 pill a day. People with TB, even though we've known about TB for centuries, are still taking handfuls of pills that cause extreme side effects, right? We don't even have good formulations for children or for pregnant women. We don't really know. Doctors are sort of guessing if formulations for how to treat people with TB, and mostly TB in this globally is in sub-Saharan Africa, in South Asia, and in the former Soviet Republic countries. And so, we have to think about the sort of implications of reproduction and reproductive justice as it relates to TB. Lastly, hepatitis C. Just 2 years ago, we got the first drugs that cure hepatitis C, which causes liver disease, and many people die from. Thank you. But again, the issue that we have with hepatitis is the expense of the medications. The medications that now are available to cure the disease cost anywhere from $84,000 to $100,000 per cure. And in most cases, we're talking about a total of 94 pills, right? So, pills for about 90 days cost about $100,000. Right? And so therefore, Medicaid and insurance companies are making determinations about who gets access to those drugs, right? So state Medicaid offices are making determinations that if you currently use drugs or alcohol, and if you have hepatitis, you can't get access to the drug, and those are probably the people who need it first the most. So just some quick things, I think, moving forward that I want us to consider. As we think about kind of the intersections between infectious disease and reproductive justice, and thinking about kind of research and science activism. I want to think about these religious freedom laws that we're seeing pop up around the country that are often kind of framed as anti-LGBT legislation, which is true, right, in terms of their inception. But I would also offer that they have the potential to ultimately challenge the Civil Rights Act, right, which would then, basically gut federal legislation we have that protects race, sex, religion, and other protected classes if moved through a conservative Supreme Court. It could undermine the Civil Rights Act, right, if those bills move to that level. Secondly, they also create context that open the door, which we've already seen, to challenges by employers who provide insurance to their employees to access to abortion or reproductive care, access to transgender health care, HIV treatments, or access to PrEP or birth control, all on the basis of some notion of religious freedom. So one of the things I want to say to you is that for those of us in whatever social movement or organizing that we're in, whether it's in repro justice, HIV, whatever, particularly where science is concerned and being activists around science and research and treatment, we need not concede that space to white men, frankly. I sit in way too many rooms. Talking about any of these diseases that primarily impact black and brown people all over the globe, and I am the only person of color and often the youngest person at 41 in the room, right? It's a problem. I also want us to think about, and I know we're in a particular, we're in a particular movement moment where a lot of focus and attention, and rightfully so, on police violence and murders of a range of folks, whether folks, indigenous folks, black folks, whether they're men, cisgender, trans, or what have you. And I think that that work is important. But I think that we need not to kind of make the mistake to think that state violence is only about police violence, right? That many folks in our communities unfortunately meet their untimely deaths and premature death, not just through police or prisons or jails or detentions, but also in the education system, in hospitals and clinics, in institutions that institutionalize those of us who are disabled, who have mental health challenges, so on and so forth, right? Through land, through food, through a whole range of places. And so I want us to think about the expansiveness of state violence not just happening at the end of a gun by a police officer, and that perhaps if we get there, we can then begin to dismantle some of the kinds of misogyny that we think about, because if we still are only focused on this particular kind of state violence, which is still, if you think about it, a very masculinized notion of death and state violence. So, but if we're thinking about health, and infectious disease and other ways through which people meet premature death or meet kind of trauma through engagement in institutions, we can then create a more full movement that is really about transforming our society. Thank you.